So my name is Michelle Iandiorio. If you could stop share and I'll put my slides up. I am a professor of internal medicine at the University of New Mexico and the clinical director of South Central ATC. And lovely to see you all. We have a pretty small group, which is terrific. We're going to talk about antiretroviral basics. I have some slides prepared to go through some basics, and you can have these for reference. But really what I'd like to hear are your questions. And so please feel free to use the chat function to add your questions or comments, or feel free to unmute, which is in the bottom left-hand corner of your screen, and we can and you can ask your question at that time. Would anyone like to share something that they want to make sure that we cover in today's session? So feel free to put that in the chat function or go ahead and unmute, and I'm happy to hear what you want to make sure we cover today. Well, I can't see many of the people, and that's okay if you don't want to share your screen or share your video, but if you'd like to, that'd be great. And if you have a question, what do you want to make sure that we cover in today's session? Great, lovely to see you all. On your Zoom screens, if you see on the bottom, there's a row on the bottom. If you click on participants and then click on chat, you can see all the participants there, and whether they're on video or muted or unmuted. You will also see a raise the hand function or yes and no. And you can also see on the bottom the chat, and if you chat to everyone, we can see your questions. Great, so we have one here, medication types and when to use. Terrific. We'll be sure to address that. If we don't, hold me accountable and we'll make sure that we answer your question. Anyone else like to share a question, either using your audio or typing in the chat? Let's see, some HIV primary care pieces like pneumonia treatment for patients with HIV. Yeah, so I'm not sure we're going to get to that because it's antiretroviral basics. So if we have time at the end, I certainly will address that question, but I'm not sure we'll have time to specifically talk about that today. We can talk a little bit about the two drug therapies. So thanks. When it comes up, please remind me. Basic mechanisms of actions in different medicines. Great. So let's get started. Again, it's a little tricky for me to see the chat when I'm sharing my screen. It's not impossible. It's just a little tricky. So if you want to unmute, or I'll periodically plan to look at that chat function. Hang on a second. I'm gonna move that over, and then I want to see you all, and I can't see everyone from my view, but hopefully I can see some. Can someone please use the chat function and let me know if you can see the slides on your screen? Okay. Yes, terrific. Thank you so much. So I'm going to turn off my video right now because I will have let's see, I'll have better audio, that video, and then I'll come back when we're doing Q&A. So introduce myself. I have no conflicts of interest. And then we're going to talk about initiation of antiretroviral therapy. Really, when we're talking about people with HIV and the recommendations for when to start people and which regimens are suggested, but we can also talk about some switch if we have time, and also you know, what if someone's on a regimen, should we keep it on or change it? We're going to talk about the regimens and then drug interactions, toxicity, etc. So because it's a antiretroviral basics talk, I wanted to really start with just HIV natural history as a background. So if we look at the CD4 count, if we start with a normal value with acute HIV infection, we see decline in the circulating CD4s, because remember the CD4 count is we draw blood and we count what's circulating, and those get infected and killed basically and removed from the circulation, and then there'll be marginalization and there'll be recruitment from the lymph nodes into the circulatory system. And so we see that CD4 bump up, and then there's a slow, steady decline. And most people who do not have other medical conditions that would drop their CD4, it takes about, on average, a decade to go from a normal CD4 count to one that's less than 200. And less than 200 is our stage 3 HIV. And at that point, patients are at risk of opportunistic infections and malignancies. And so our goal, of course, is to have people in asymptomatic HIV with a normal CD4 count throughout their course. And so the earlier we start therapy, the less decline we're going to see in that CD4 count. If we do, however, have patients who start at a lower CD4 count, our goal is to go backwards in this slide, and we can increase the CD4 count over time. And so antiretroviral therapy can be started at any point here. I want to just briefly comment on the stage 3 HIV/AIDS. So right now it's, we call it stage 3 HIV, and AIDS is really historic before we fully understood what was the cause of this disorder, and is a quite stigmatizing term. And when it was used on the early days, what it meant was someone was going to imminently die. And right now, if we start someone who's stage 3 HIV with a CD4 count less than 200 on antiretroviral therapy, we can improve their immune system and have that CD4 count rise up. And so imminent death is not inevitable. And so it's really not an appropriate term at this time, although you'll continue to see it referenced because of its historical reference, basically, but we'll use stage 3 HIV. So when we talk about clinical assessment, I have a patient with HIV. There are two pieces of information that are really important to me. One is the stage of the disease, and then the second is the control of the infection and whether they're on antiretroviral therapy. So CD4 count is used to stage the disease. So stage 1 is asymptomatic with an absolute CD4 count of over 500 cells per microliter. Stage 2 is between 200 and 500, and stage 3, as I talked about, previously known as AIDS, is a CD4 count less than 200, so that's the absolute CD4 count, less than 14%, and we use percentile because sometimes it's a more accurate picture of if we have two CD4 numbers, is there a real difference or not? We use that CD4 percentage, which can really help. In addition, in pediatrics, because they're a normal range of CD4 changes with age, they use the percentage more than the absolute count. And then if someone has, no matter what their CD4 count is, if they have an active opportunistic disease or malignancy, then that would be considered stage 3. And then the second is, are they controlled or not? And so this is used to monitor the response to antiretroviral therapy. So we say well controlled when the viral load is undetectable. We might say suboptimally controlled, or uncontrolled if there's a viral load that's detectable. And that's done by the HIV RNA quantitative PCR, which is reported as copies per milliliter. So I might have someone who's stage 1 uncontrolled. So ideally they're diagnosed early on in an infection before they've had a significant decline in their CD4 count, but they have not yet received medications. And so I'm going to start them on medications. And so initially they're uncontrolled. And then after several months, they will have undetectable viral load and they will be well controlled. So you can also have a patient with stage 3 HIV who's well controlled or not controlled. So two pieces of information are really key. So the guidelines for when to start treatment in patients with HIV really, really helpful now because they're so easy. So it's everybody. And so there are a few exceptions to every rule. So if we have time today, we'll talk about a few exceptions, but really the rule is every single patient right away as soon as you can. And really as soon as you can really depends on your setting and what's happening with the patient otherwise. And so is the patient ready? That's really important. So there are some must start in conditions. So if someone has stage 3 HIV, right, they have an active opportunistic infection, including tuberculosis. If they have an HIV associated nephropathy, and that's direct kidney disease from HIV replication, or co-infection with hepatitis B and C because liver disease progresses more quickly in patients with uncontrolled HIV, and then pregnant women both for herself and also to reduce the vertical transmission of HIV. So everyone as soon as possible. So what I want to talk about today are our tools in our toolbox to control HIV infection. And so in order to understand the antiretroviral classes and their mechanism of action, I think it's helpful to review the HIV life cycle a bit. So we'll discuss the life cycle briefly to review these, the sites of action of various antiretroviral classes. So we'll start at the very beginning if we have a free virion here. And what you'll see is the virus genetic information and then the enzymes inside. And then you see a capsid, and right here in that, what is that, an octagon? No, I don't know what that is. Anyway, and then a membrane around it, an enveloped virus, and then these are the receptors here. So what has to happen in order for HIV, I think hexagon, no, I don't know what it is, I'm distracted. So maybe if we get this, somebody could use it in the chat function, what is that? So what has to happen in order for HIV to infect this activated CD4 cell is that first there has to be binding between the two cells. And so the HIV virion needs to find the CD4 receptor and then also find a co-receptor, and those co-receptors are CCR5 or CXCR4. The majority, particularly in early infection, use CCR5, but some viruses can use one or the other or both. And then once there's binding of both the CD4 receptor and a co-receptor, then what happens is the two membranes fuse, and so then the contents of the HIV virion can be spilled into the cytoplasm of the activated T cell. So there are some medications that work here at the entry inhibitor, so prevent this virus from either entering into the cytoplasm. And those include the GP120 blocker. This is the new FDA approved medication that interferes with the virus attachment to the CD4 receptor, a CD4 post-attachment inhibitor that blocks HIV from binding to the co-receptors, a specific CCR5 inhibitor, and then a fusion inhibitor. So 4 different medications in this entry inhibitor part. Then if we go to the next thing, when the virus material comes into the cytoplasm, you can see the genetic material of HIV is an RNA virus, but in order to infect our cells and integrate into the host genome, it needs to convert from RNA into DNA. And this is a very, very key enzyme that HIV carries, and it's called the reverse transcriptase. And there are 2 different classes of medications that will disrupt the activity of that reverse transcriptase enzyme. And so if the RNA cannot convert into DNA, then you can't truly have infection and certainly not replication. And so those we'll talk about in a little bit more detail. So again, let's talk about these, orient you here to the slide on top here. This is the HIV virion, and you can see it's an enveloped virus here, and there's some proteins, the GP41, and then you can see below that the GP120. That is the section of the HIV that interacts with the CD4 cell, and that's the receptor. So on the bottom, if we see host cell, that's the activated CD4 cell, and you can see again there's the host membrane, and through the membrane we can see which is green, the CD4 receptor, and then you can also see these co-receptors, and one of them here is labeled CCR5. And so if we talk about our GP120 blocker, that's here. So fostemsavir, the most recent FDA approved medication, blocks this interaction between the HIV protein and the CD4. And so if they can't attach to each other, guess what? No infection of that CD4. And so that's an exciting new medication, currently only approved for multi-drug resistant virus. This is not for treatment naive, but important tool in our toolbox for patients who don't have other options. What else? This is also another agent which is approved for multi-drug resistant as opposed to treatment naive, and this is a CD4 post-attachment inhibitor. So once the GP120 attaches to the CD4, then what happens? Then what has to happen after that is that the HIV attaches to the co-receptor before it can get in. But the ibalizumab will prevent that attachment to the co-receptor, and that's either CCR5 or CXCR4. Our other entry inhibitors here, Moraviric, which is a specific CCR5 inhibitor, so it's not does not have any activity for virus that uses CXCR4. So in order to determine if Maravirac is an option for your patient, you would need a recent tropism assay, and the information from that test will tell you if it's CCR5 tropic or not. And if it says tropic to CCR5 only, then Maravirac might be an option. Again, Maravirac not currently approved for early infection, but rather reserved for patients who are multi-drug resistant. And then here, a fusion inhibitor. This was the first entry inhibitor on the market. It's an injectable, so rarely used now, but it's still a tool in our toolbox if we need to use it. And that basically prevents the fusion of the HIV envelope with the host membrane. And again, if those membranes don't fuse, then we can't have the contents of the HIV virion spill into the host cytoplasm. So again, the reverse transcriptase inhibitor is really a very, very key enzyme, reverse transcriptase. And so our backbone, and we'll talk mostly about most of the regimens you'll see, will include 2 NRTI, so nucleoside reverse transcriptase inhibitors. And what nucleoside reverse transcriptase inhibitors are, basically they pretend to be a nucleoside or a nucleotide, but they're not really a human nucleotide. And so if you see here this zipper, which is what I call on the bottom here, it's like having a broken part of your zipper, that this fake nucleoside gets in here and it sticks, and so there cannot be further transcription, and so that completely blocks that enzyme. So this is a very, very key class, and again, most of the time we use our backbone of antiretroviral therapy will include nucleoside reverse transcriptase inhibitor. The 2 current FDA approved agents for PrEP, both tenofovir and emtricitabine, are 2 examples of NRTI, so they're used for both treatment and prevention. Another way to block the reverse transcriptase enzyme is a different mechanism. So that's the non-nucleoside. And so it basically changes so that the enzyme won't work anymore, but it's a different site. And because it's a different site, one could actually use an NRTI with an NNRTI. So 2 different sites, but affecting the same enzyme. So let's go back to our life cycle here. So after receptor attachment, membrane fusion, and the reverse transcriptase from HIV RNA to DNA, HIV has 2 other enzymes that now come into play in order for the HIV genetic material to become a mature and infectious virion. Oh, I just saw trapezoid. Oh my gosh, I love you, Megan. Thank you so much. Okay, so so what happens when the HIV RNA is now DNA and now needs to integrate into the host genome, and that's done with the HIV enzyme called integrase. And there are the class of medications called the integrase strand transfer inhibitors that act so that enzyme cannot work. If, let's say, the drug isn't available there, but HIV DNA is replicated, basically what you have is some genetic material here in the cytoplasm, and then this budding off of this HIV, but it's not a fully mature or infectious virion because it has to be changed from this protein into its genetic material and then those 3 enzymes. And so in order for that to happen, its 3rd enzyme comes into play, the protease, and protease inhibitor class blocks that medication. And so here I have an example here of the integrase strand. So what's supposed to happen is the HIV DNA uses this enzyme integrase and then clips the host DNA and stuffs itself right in there, but the integrase strand transfer inhibitor blocks that enzyme so it won't work. Here, the protease inhibitor, again, it will fit into that site of the protease and prevent it from working. So let's see, so here are all the current antiretroviral medications. If you're new to HIV and you look at this list, it can be very overwhelming, particularly when we refer to antiretroviral therapy, but sometimes by their older names, research names, and then by abbreviations or the full name, and then sometimes brand versus generic. So it can be quite a lot. What I want to just highlight here is I've bolded the agents that you will see that are in recommended regimens. So there are multiple medications on here that may be utilized for people with multi-drug resistant HIV, but for our first line, you'll see just the bolded. And so it will be important really to learn those. I did leave out the bolding of zidovudine, and we do use that in infants and also for peripartum to reduce the risk of vertical transmission to baby. But really for our adults, there really is no longer an indication to continue zidovudine because of its its extensive toxicity list that we would want to switch somebody to something else. So I just want to stop for a second and make sure that I'm looking at the chat function. We want to talk about resistance and INSTIs. We'll talk about that. Contraindications from first line therapies. Yes, let's do that. Basic mechanisms and clinical correlation. Women, yes, we'll get to that. Juluca, so that's a 2-drug combination. Yes, let's talk about that. Pregnancy, I think we'll get to that. It's a case toward the end. I may get to the CD4 count. I'm going to come back a little bit later if I can. Okay, great. So lots of good options here. So let's talk about what the recommendations are. So the recommendations really, and this is from the true large organizations that give us our antiretroviral treatment recommendations, so the IAS and the DHHS, both agree that our preferred regimen are 2 NRTIs. Again, I said that was the backbone. They're really key to block that enzyme, and then integrase strand transfer inhibitors. So why that particular combination? Again, lots of evidence that when we include the NRTI class, it's really quite essential. And the NC class has really fewer toxicities, fewer side effects, fewer drug interactions, and is associated with a quite rapid drop in the viral load. So people have a more rapid rise in their CD4 count and drop in their viral load. So that's both good for the patient and from a public health standpoint. So this may or may not be the appropriate regimen for your individual patient. And it has been brought up several times in this meeting that guidelines are just that, guidelines. And so you can consider a particular patient that you have in front of you that maybe should use one of these alternates. And so the alternates here are their 2 NRTIs, again, that backbone, plus a 3rd class. So if we can't use an INSTI for whatever reason, a boosted protease inhibitor might be a good option for you, or an NRTI. And there's currently 1 FDA-approved regimen. This is an example of one of those 2-drug regimens that was mentioned, the 1 NRTI with an INSTI, and I'll talk about that, okay? So all of these could be potential options. What you do not see here are any of those entry inhibitors, because as I said, those are for multi-drug resistant virus. So what are our initial regimens? Again, I think it's hard to go through these in a sort of presentation, but maybe helpful for reference slides later. And these are all pretty high ratings. So our regimens you can see on the left here, all of these are integrase inhibitors. So bictegravir, dolutegravir, raltegravir. Raltegravir can be given twice a day, or there's an extended release formulation. It's still two pills, but it's just once a day. And then dolutegravir is just 1 tablet. Bictegravir, tenofovir, alafenamide, and emtricitabine is only given as a single tablet regimen, and is quite common. Dolutegravir, abacavir, lamivudine is also a single tablet regimen. And however, we need that HLA-B5701 to be negative, and we need those results back. So abacavir can be associated with a hypersensitivity reaction, which can be associated with rash, fatigue, elevated lactic acid, elevated liver enzymes, and can lead to death. And so that's quite the opposite of what our goal is. And so in the United States, before prescribing abacavir, we must have the results of the HLA-B5701, and it must be negative. And depending on your lab, that could take several weeks to come back. And so it's challenging to prescribe that medication for if you're thinking about starting medicine right away. It is possible to have a hypersensitivity reaction even if the HLA-B5701 is negative. So we still want to monitor patients, and really symptomatically we monitor them. We don't routinely do lactic acid levels, but we just monitor them clinically to ensure that they don't have any evidence there. So HLA-B5701 is the genetic material of the human being. So it's not something that you check for the virus. It's just basically certain people of certain backgrounds will have this allele, and that allele has been associated with this hypersensitivity reaction. So you only really do test once in a life because it's about the human being. It's not about the virus. It's not like checking the resistance pattern. So I'll talk about Hep B. It can be used in chronic kidney disease. So all of these agents can be used in kidney disease. Here on this list, abacavir and dolutegravir, but lamivudine can also, but it would need to be dose reduced. So you couldn't use a single tablet regimen, but that might be an indication that you may want to use that particular medication. Chronic hepatitis B, if you see in all the other options here, you'll see tenofovir and emtricitabine or tenofovir and lamivudine. Hepatitis B is treated by both tenofovir and emtricitabine, and so if you have a patient with chronic hepatitis B, it's really important that our preferred regimen would include both tenofovir and emtricitabine or lamivudine. So let me talk about that. So emtricitabine and lamivudine, I think of them as fraternal twins. So basically they act in the same way, so we would never use them together, but they are interchangeable. You'll see one associated with another medication due to basically drug companies and how they're formulated, but you can emtricitabine and lamivudine essentially think of them as the same. So what would you want to know? So emtricitabine and lamivudine, basically, if you think about that, the vast majority of antiretroviral regimens include one of these medications. So the most common medication used, it is very well tolerated with very few toxicities. And so it's really a really magnificent medication. Again, NRTI medication. So I call it kind of a free drug because we're not adding toxicity and because there are so many combination medications with these meds in it that you're not necessarily adding extra pills. Again, important to know that in lamivudine, particularly when the creatinine clearance is less than 30, and some people say less than 50, that we would dose reduce. What else can I say about this slide? So a question I had about the dolutegravir lamivudine. So this is the one medication approved for treatment naive patients to start a 2-drug regimen. And otherwise, the rule is 3 active drugs with just a few exceptions. And so this integrase inhibitor dolutegravir is very excellent. It's an INSTI, so those are very effective medications. And then because I talked to you about how important it was to block that reverse transcriptase enzyme, we see that dolutegravir plus lamivudine, and this is co-formulated in a pill that can be very effective for the treatment of HIV. It can be used in chronic kidney disease. Again, the fixed dose combination you wouldn't necessarily use if their creatinine clearance is less than 30, but you could separate them and use that. So that may be a really good option. And particularly if you don't have the HLA-B5701 back or you don't want to use abacavir for some other reason. At this point, there are studies ongoing, but at this point, we're not using this particular regimen if the viral load is very high. And so this may or may not be a good option for rapid start if you don't have the results of the viral load. So kind of depends on how rapid your particular rapid start is. And because this includes only one drug that's active against hepatitis B, the lamivudine, this would not be appropriate if you have a chronic hepatitis B. You'd want to include the tenofovir. So what else? Because I said here, somebody had asked me about resistance, and it's really hard to talk about antiretroviral therapy without talking about resistance. And really what's important is emtricitabine or lamivudine are included in nearly every regimen, particularly, and all of the regimens for treatment naive patients. And so the most common medication used is either emtricitabine or lamivudine. So it's not surprising to note that the most common mutation against antiretroviral therapy reduces the susceptibility to emtricitabine or lamivudine. That's the M184V. And so if I have if I was infected with a virus that had the 184V mutation, then basically this last drug, the lamivudine wouldn't work, and I would only be on monotherapy with dolutegravir. And that's why we want the results of the genotype testing, at least at this point with the guidance. There's a question here, most recent information regarding abacavir and the potential for cardiovascular risk. I have some patients who have risk factors for a cardiovascular disease, but also signs of kidney injury. Yeah, so really great point. So I personally do not start anyone on abacavir anymore. I often switch people off abacavir if they have significant potential for other risk factors for cardiovascular disease, or they currently have risk factors for cardiovascular disease. If someone's on abacavir and they're otherwise doing well and no other risk factors for cardiovascular disease, they could maybe continue. So I agree, since kidney disease is a risk factor for cardiovascular disease, I personally wouldn't pick that medication, but there are some instances where you might want to do that. Signs of kidney injury. So if the kidney injury is from the tenofovir and you have basically proven that, right? So they have, like, let's say Fanconi syndrome, you're saying that they have proteinuria and they have phosphaturia, elevated phosphate levels in the urine, then of course we would want to avoid tenofovir. However, if someone has preceding kidney disease, you can use tenofovir as long as their creatinine clearance is above 30. So it depends on which formulation. In that case, I would use the TAF formulation, tenofovir alafenamide, which can be used down to a creatinine clearance of 30 or higher. So I hope that helps. But in that case, otherwise, we might consider picking a regimen that is basically nuke sparing, like maybe this last regimen or some other alternatives. What is the thought behind needing to use 2 different NRTIs? That's a really great question. I think it's partly historical that when they've done quote unquote nuke sparing regimens before, they saw that they, at least with the older protease inhibitors and older NRTIs, they saw that they didn't have as good a drop in the viral suppression, and so that's an issue. The other thing is I talked about mutations. So I didn't actually really talk about mutations. I will though, but there are mutations in the NRTI class. Basically, they're cumulative. They can occur over time, and so it's all probability gain. And so if you pick 2 medications, let's say in the same class, but they work in a little bit different ways. If someone had one mutation, but not another, then if I use 2 drugs, I increase the probability that I have a good regimen. And so those are just some of the things to think through of why historically we've used 2 different NRTIs. Great. So there are some alternative regimens. Again, this is a list that would be really boring if I went through all together, but I put on, you can see just on the right some of the things. So there you can see some examples of a boosted INSTI or a boosted PI or an NRTI. So sometimes we may have different preference based on insurance coverage, kidney disease, liver disease, whether it has to be given with food or not, prior history. So we might want to use these other agents. I want to note here the rating here C1, so that means this is expert opinion. But there's some growing data on the effectiveness here. This one, the second from the bottom, is an example of a nuke sparing regimen. So there is no blocker to the reverse transcriptase enzyme in this case, and that's boosted darunavir, a protease inhibitor with an INSTI, an integrase inhibitor. So there's some data there. Some people will extrapolate and replace the raltegravir with one of the newer agents like dolutegravir. We've seen that, but we haven't seen the studies yet. So what's the advantage here? This is a regimen that can be used in chronic kidney disease, including dialysis. However, there is less data that we would recommend this when the viral load is high or the CD4 count is low. And so again, if the viral load is really high, you want to use the best regimen. And what we have so far, it looks like that would be a 3-drug regimen. Again, increasing the probability that all of your medications will have activity against the HIV that's replicating, and try to hit it at multiple targets to get that viral load to stop the virus from stopping to replicate as much as possible. Down at the bottom here, this is basically we had seen before dolutegravir and INSTI with lamivudine, and here's the example of a boosted PI, darunavir plus lamivudine. So probably the highest barrier to resistance, darunavir, ritonavir, it's a protease inhibitor. HIV has to have multiple mutations in order for it to be resistant against darunavir, which is boosted with ritonavir. So it basically was initially put out on the market specifically for virus that had multiple mutations against other PIs. So really high barrier to resistance in this medication. So it's a great option for patients who maybe have underlying resistance. And then dolutegravir and bictegravir, the newer integrase strand inhibitors, also appear that they may be just as high a barrier to resistance. And so those are considered really good too. And so when we include those medications, we might see that two drug therapy is adequate. Again, the darunavir with ritonavir can be used in kidney disease, including dialysis as well. So you've seen before darunavir with cobicistat as a booster, but cobicistat is not used when the creatinine clearance is less than 30. So what are some considerations I need to think about before initiating antiretroviral therapy? And really not just initiating, but maybe like restarting or modifying. So what's the patient willingness to initiate HIV treatment, right? They may think, well, I'm going to die anyway, what's the point? Or they may have heard some lawsuit against the medication, or they may have, I don't know, some problem with taking medication every day. So really we want to help prepare them to take the medication and address their specific concerns around that. Pregnancy tests, so childbearing potential is relevant when we think about certain antiretrovirals, and we'll get to that in a little bit later. I talked about hepatitis B co-infection, so if they have hep B surface antigen positive, we want to include tenofovir and emtricitabine. What's their renal function or their likelihood of renal disease? Other comorbidities that really would make me want to use one class or one specific agent over another. Those are all the things that I consider. What are their over-the-counter medications or other medications? Many people think about that. I have to ask 3 or 4 times, what else are they taking over the counter, because they do not see over-the-counters as medications, but they can interact with our antiretrovirals. So really asking at every single visit. Some medications require food to be absorbed, so that may be problematic for your patient. Let's say they are homeless and have irregular meals, or they have some other reason why that might be a problem. And then if we have this information, again, we say if we have this information, we always check the CD4 and viral load and the resistance testing. However, with rapid start, meaning we start right away before we have all the lab results back. And so that you may not have the information ahead of time. But we do, if we do have these lab results, then there are certain combinations that we would not use if the viral load is really high and the CD4 is low, because they're just not considered as strong a medication combination. And then really very key, access to medication. So yesterday there was a panel discussion, and one of them was a question to the audience was a newly diagnosed patient, would you start them right away? And what did right away mean? Basically in the emergency department where they were diagnosed, 1 to 2 days later, from outpatient clinic, a few weeks later, et cetera, et cetera. And really one of the things is the access to the medication. So if someone's not insured, or they don't have access to the assistance programs or Ryan White enrollment, that kind of thing, then we really want to make sure 1 or 2 days of antiretroviral therapy doesn't do any good, right? When we start medications, we want to ensure that patients are able to continue to fill these medications and have continuous access to them to really do the job. So there's some pros and cons. So I've started here with the NRTI class. So this is the backbone. Again, I did not include emtricitabine or lamivudine because that's a given. They'll be given with all of those, and those are very well tolerated. Some people will say some nausea, but really very well tolerated. So here we have abacavir. So it can be used in chronic kidney disease, even in dialysis, and there is a single tablet regimen. But as we talked about, for con, the hypersensitivity reaction may be an issue. We need to have that lab result that says HLA-B5701 negative, and that risk for cardiovascular disease events. So really not considered first line in most cases. And then there are the 2 formulations of tenofovir. They both start with T, so TDF, tenofovir diproxyl fumarate, which is the older version. There is now a generic available, so that's a pro, and there are several single tablet regimens available. For this medication, it is metabolized by the kidney and also can cause kidney toxicity. So we need a creatinine clearance at least 50, and we monitor bone and renal toxicity, particularly in older patients or patients who may have other risk factors. It looks like tenofovir DF and TAF are both pretty safe in younger people without other comorbidities. The tenofovir alafenamide is the newer formulation of tenofovir, requires a lower dose, and it's okay to use as long as the creatinine clearance is 30 or above. and really less potential for that bone and renal toxicity. And there are single tablet regimens available, but some data that's has been presented at this conference so far certainly suggested that this may cause weight gain, although it may be that the data looks like maybe the TDF suppresses weight gain. So really unclear whether this really is truly the cause of weight gain or not, but it is a possibility. So in addition to our NRTI background, or what else are we going to use? The INSTI is the recommended, and our alternatives, the boosted PI and the NNRTI. So what about INSTIs? They're very well tolerated. There are fewer drug interactions. There's a rapid viral load suppression. With the PI and NNRTI-based regimens, it often can take 3 to 4 or 5 months to get from a high viral load down to undetectable. In the INSTIs, I've seen anywhere from 1 to 3 months to get to undetectable. So really quite fast. There is a high barrier to resistance, so that's good. What does that mean? So if I have a virus that is not pan-sensitive, right, if there are already some mutations to other agents, that may be helpful. Or if I'm a little bit concerned about, will someone forget some of their medications? This has a high barrier to resistance. And there are many single tablet regimens. Again, growing data that the INSTI class can cause weight gain. Dolutegravir in early pregnancy may be an issue. We'll talk a bit more about that. And then some QTC prolongation, particularly in raltegravir. Yeah, we'll talk about the dolutegravir within 6 weeks of conception. So really, if when women were exposed to dolutegravir at the time of conception and early trimester, before the formation of the neural tube, we do see some very slight increased risk of neural tube defects, but growing data shows that maybe this is not as much of an issue as we originally thought. So we'll talk a little bit more about that. So it's not an absolute contraindication. Boosted PIs, again, high barrier to resistance, so may be very helpful for someone who you want to start on therapy, but maybe is on and off because of psychosocial reasons or something. Really good option. And there is one single tablet regimen available. But the drug interactions and the necessity to take with food can be a barrier. And in RTIs, there are single tablet regimens and a generic available. The cons are some drug interactions, some neuropsych side effects. So particularly with the older NNRTIs like efavirenz and suicidality. Some have food requirements, so rilpivirine does, and also requires an acidic stomach, and some less effective when someone has a high viral load and a low CD4 and a lower barrier to resistance. So the older NNRTIs, just one mutation could lead to resistance. And so really important when we talk about getting prior resistance information, so a genotype, one of the most common transmitted mutations, so someone who has never been on medications themselves but was newly infected with HIV from someone else, that they may have a mutation, the K103N, that basically makes them resistant to efavirenz and nevirapine, some of the older NNRTIs and some of those generics that are now available. So really important to get that resistance information before starting that medication. So drug interactions are really very important to recognize, and really a key thing to take away from this session is just assume there's a drug interaction and then prove yourself wrong, right? So many of the HIV medications are metabolized by the cytochrome P450 mechanism in the liver. They may have potential drug interactions with other medications that are also metabolized by the system. And so they may be inducers that can decrease the level of other drugs, or inhibitors that can increase the level of other drugs. And so really we recommend that with any new medication, or if someone has side effects, we want to check for drug-drug interactions. So this is a terrific website here, the Liverpool Drug Interaction site. This is doesn't cost anything. You can put that in your favorites and your internet check. Specifically what we see are the boosted. So those inhibit cytochrome P450. So all of your protease inhibitors should be boosted. And then there's that one INSTI that's boosted. And they're boosted either with ritonavir or cobicistat. And what can happen is other medications that utilize the cytochrome P50 will be increased, just like the protease inhibitors are increased. So the benefit of boosters is that allows for fewer pills, fewer times a day. So that's a real benefit from the old days where they didn't use them. but it can interact with some of our very commonly used medications. And so some of these here, intranasal steroids, many of these now are over the counter, like fluticasone, and that would be an absolute no-no for somebody who is on a boosting, an antiretroviral therapy with a booster and an over-the-counter intranasal steroid, because that metabolism of that steroid can be slowed down and someone can present with Cushing's, which is overwhelming cortisol levels, and they can have weight gain and hypertension and glucose intolerance and all of those things. So it includes intra-articular injections. And so as a rule, we like to avoid boosters whenever possible, particularly if people have these other conditions that may need the treatment with steroids. Just FYI, at least this time of year in our neck of the woods, allergic rhinitis is so common. So important for you all to know that beclomethasone is totally safe. Statins, there are multiple drug interactions with statins, selective serotonin reuptake inhibitors, all seizure medications. So really important to check through all those. Some medications require an acidic stomach. So the protease inhibitor atazanavir and the NNRTI rilpivirine require that acidic stomach. So we do not use with a proton pump inhibitor. The integrase strand inhibitor, transfer inhibitors, can chelate with cations. So this is where that over-the-counter medication is so important to find out. So if someone takes calcium carbonate because they have heartburn sometimes, or if they take a multivitamin with minerals, or they heard, hey, zinc is good for your immune system and calcium is good for your bones, right? Those can bind together. I tell patients that they'll bind together in your stomach and cause expensive poop, because basically it reduces the absorption of the medications, and so you don't get the full effect. So depending on the particular integrase inhibitor, we need to separate that from any cation containing supplement by at least 3 to 6 hours. Dolutegravir can increase the metformin dose, and so we don't use, we have a higher max dose there. So yes, so basically iron, calcium, magnesium, zinc, all should be separated from the integrase inhibitors. So all of the integrase inhibitors, with the exception of raltegravir, raltegravir is BID, although there is a Q-day dosing option. All the rest are Q-day. So it's a lot easier basically to separate, you know, their multivitamin or their calcium or some such thing from that. So again, depends on which agent it is, whether it's at least 3 to 6 hours. So you want that cation to be completely out of their stomach before they get the integrase inhibitor. Oops, sorry. So we want to prevent resistance to antiretroviral therapy. So again, the goal of antiretroviral therapy is to stop the HIV from replicating. That's the main goal. And if the virus stops replicating, then the immune system can recover. If there's replication of the HIV in the presence of drug, then those mutations that are resistant to the particular drugs that the patient's on will be selected for, and will basically encourage the addition of more and more resistance mutations. And there's a specific breakout for resistance if you're interested in learning more about that. So antiretroviral therapy from at least 2 different classes of medications. Again, it's a probability game, so you want to make sure that you increase the chances by using at least 2 different classes. We want to avoid those drug interactions, which again, you don't have to memorize them all, but we want to look it up, including over the counters. Avoid interference with drug absorption and promote adherence. And that's really, really key. It's very hard to take these medications every day of one's life, right? And so yes, particularly the newer antiretroviral therapy, if someone forgets every once in a while, it's fine. They're just human, it's okay, but we really want to support adherence as much as possible. The key thing is if the viral load is undetectable, then the virus is not replicating for all intents and purposes, right? So that means no new mutations are occurring. So as long as the viral load continues to be undetectable, then you are preventing the further development of HIV resistance. So here's what I'm talking about here. If I have someone on antiretroviral therapy, but let's say it's not adequate therapy, so it has low levels or maybe the wrong drugs, I might block some of the HIV that's susceptible, but some of those HIV that have mutations against the drugs that they're being exposed to will start replicating and have that competitive advantage. And so then it will be harder to treat that particular virus. The question here is, do you suggest taking vitamins first before antiretroviral therapy? It really doesn't matter. It just matters that you're separating them. So if you really want to be careful, it should be at least 6 hours. I usually tell them just take it at the opposite time of the day. So if they take their, antiretroviral therapy in the morning, then they can take their, for breakfast, they can take their supplement at dinner or vice versa. So what are some causes of resistance? So really basically inadequate drug therapy, or it's not being absorbed well, or someone's not adhering, drug interaction. It is possible to become infected with a resistant virus during initial infection. And I mentioned the most common transmitted resistance is with the mutation K103N, and that makes the virus resistant to efavirenz and nevirapine. Those are NNRTIs. And the reason why NNRTIs are not included in our treatment options for rapid start, because we don't have the resistance information back by that point, and a patient is more likely to have resistance against one of those first. It is also possible to become infected with someone else's virus that's resistant to the medications that you're on, and so that is an issue as well. So genotype testing is part of the routine labs before starting someone on therapy. Again, we're doing a CD4 and a viral load, and also the genotype. Again, if you're doing rapid start, you do not necessarily need to wait for the results of the genotype test before starting. However, you should have that cooking. If you have a patient and they're restarting, so let's say they were on antiretroviral therapy, but they were lost to care for whatever reason, now they're coming back. Depending on their prior drug exposure, you may want to wait for the genotype results before starting a regimen, particularly if you were concerned that they may have developed resistance to medications from their prior, let's say, suboptimal adherence or something. So when do we want to check it? At baseline and new infection, and whenever we don't see an undetectable viral load in the predicted time period, basically. So what it does is it compares the genetic makeup of the patient's HIV versus the wild type. And wild type is basically has the competitive advantage, right, to a virus that has mutations. It has the highest replicative capacity, so it replicates the highest, the fastest, which is the whole point of HIV, is to make copies of itself. And so wild type makes copies faster than any virus that has mutations. And also wild type is a pan-sensitive virus. So while it may have mutations, none of those mutations lead to the resistance of antiretroviral therapy. And so that's the really key part. So what we're looking for are mutations that lead to resistance to particular agents. So when do you order an integrase genotype? That's a really interesting question. So it depends on your particular lab, how you order the genotype testing. So the classic genotype testing looks for mutations in 3 classes only, right? The NRTI, NNRTI, and PI. However, because the INSTIs, right, the integrase inhibitors are now more commonly used, we may want to do a genotype test for the integrase inhibitors as well. And so it's important to know what particular lab you're using and what they order for the genotype. And so sometimes you have to order a regular genotype and then a specific integrase genotype. So really what I do, I order an integrase genotype if someone is, let's say, suboptimal suppression of the viral load after starting antiretroviral therapy, that second bullet, or virologic failure during antiretroviral therapy. So if I have them on an integrase inhibitor and they're not suppressing like I want them to, or they have rebound, then I'm concerned that there's been a development of a resistance, and so I'm going to check it then. At this point, at least in my neck of the woods in New Mexico, we don't have a lot of baseline resistance to integrase inhibitors, so we are not doing it standardly on treatment naive, but that may change in future. One important part is you saw that the main goal of HIV treatment is to keep people's immune systems high and strong and keep their viral load low. And with the initial treatment guidelines of when to start, we were very focused as a scientific community on looking at the CD4 count. And our tools in our toolbox were really a lot of pretty effective or somewhat effective medications with lots of toxicity. And so we really were hesitant to prescribe a medication to someone with a lot of toxicity if it looked like their immune system was okay, and we didn't they didn't have any opportunistic infections. But what we've learned over the decades is really it's not just about the CD4 count, but it's really about the viral replication. And so there are multiple studies, and I've just highlighted the SMART study particularly, but there was studies that show that when we waited, so if the CD4 count is less than 500 or less than 350, when we used to wait to start antiretroviral therapy, we would say, well, they shouldn't be higher risk of infection. But what is happening is they have viral replication, and that causes inflammation. And inflammation causes toxicity. And so it's really about reducing overall inflammation, and we do that by completely suppressing the viral load. So we know that if someone has a detectable viral load, they are more likely to die from non-infectious causes. So cardiovascular disease, liver disease, and kidney disease. And so if you have a patient with a CD4 count that's well over 500 and they're not really convinced about taking antiretroviral therapy, remember that it's not just about their CD4, but we don't want them to have a heart attack or kidney disease. Really important, the U equals U. So in addition to HIV treatment suppressing the viral load for a patient, which helps reduce inflammation and preserve or restore the CD4 count, in addition, treatment is prevention. And so we know from the HPTN-052 trial, which was in serodiscordant heterosexual couples, and the Partner 2 trial, which is in serodiscordant MSM couples, and multiple other trials though, but those two in particular, when serodiscordant, so one person had HIV and was undetectable, and their partner did not have HIV, and they had condomless intercourse, there were 0 linked transmissions. So we feel very confident now that when someone with HIV has a consistently undetectable viral load, they are untransmissible to their sexual partners, even without use of a condom. So this is really important from a public health standpoint, that if we treat every single person with HIV and they're all undetectable, guess what? There will be no new HIV infections. And so really important for the individual patient and also from a public health standpoint. So it's all about putting someone on antiretroviral therapy. So yeah, that's not so easy though. About 51% of all people with HIV in the United States have achieved viral suppression, which is our goal. So way more room to go there. However, 82% of the people in care achieve viral suppression, still not optimal, but it's a little bit better. So it's really about linkage. So someone who has HIV, are they linked to care or are they basically retained in care? So super key. So one of the mechanisms to help with linkage and retention is to get someone, as soon as they're diagnosed, right with this interprofessional team of social workers, nurses, pharmacists, prescribers, basically to assess them, make sure that they have the resources and start medication right away. And so Rapid Start is the immediate antiretroviral therapy as soon as possible, basically after diagnosis or re-engagement. So sometimes we have a rapid restart of medication in someone who is otherwise lost to care. So there's studies in the US and in resource limited settings showing reduced time to linkage to care and reduced time to viral load suppression, some benefits in their health, reduced risk of transmission to others, and may limit the viral reservoir. So it's looking really great. So we want to start as soon as possible. How do we monitor? So CD4 is important to monitor, but we don't need to do it as frequently, right? So I say we do it at baseline, and then we want to see an undetectable viral load before we recheck the CD4, because we wouldn't expect it to improve like right away. Once the CD4 count is at a normal level, it's really optional whether you repeat that. The viral load is really key. You can see here what the recommendations are. My personal practice is I check every month until they're undetectable, and then go to every 3 months for the first year or two. A minimum number of labs here, that HIV viral load would be every 6 months. Let's see, dolutegravir plus lamivudine is only a rapid option for those who are naive, not restarting. That is correct. Thank you so much for adding that, because I mentioned if someone's restarting and they've previously been on lamivudine or emtricitabine, because I said that was the most common mutation, which would be against lamivudine or emtricitabine, I would not feel comfortable before I had information to restart someone on dolutegravir plus lamivudine if they've been treatment exposed, because I'd be concerned I was just giving them monotherapy. So thanks for that question. So I only have a minute left to go. Yes, you will have access to these slides. I have a few cases that you can see. It's important to know that about when to start medication that we might see immune reconstitution inflammatory syndrome if someone has a low CD4 count and a high viral load at the time that you start medications, and it was discussed a bit in the plenary in the setting of tuberculosis. And in addition, in pregnancy, it's important to know that we treat all women with who are pregnant on antiretroviral therapy and risk to baby for vertical transmission less than 1%. Super great news. The regimens, there are specific guidelines, the perinatal guidelines, but really the important thing is to say that most of the time we use what mom is able to tolerate and take regularly. And that's key, because the key is get mom undetectable. So yes, you'll have these slides. So I appreciate your time and attention. Thank you so much for asking those questions throughout the session. We want to make sure that you get your break, and we have an interactive session next. So you need that break beforehand. I will stay on to answer a few more questions if you'd like, but thank you everyone for your attention. Pleased to have you.
Thank you. Michelle, I do have a question if possible. My name is Mariah Jones. I'm practicing out of the Philadelphia area. I have a patient who is virologically suppressed on Genvoya and has been on Genvoya for a few years, but he's having some moderately persistent asthma symptoms. He has no symptom resolution on QVAR, so I wanted, I guess, your advice on how to manage the asthma while on the Genvoya as far as adding additional agents and the interactions that can happen with that.
Yeah, thank you so much for that question. So, you know, back in the day, we used to say, don't switch antiretroviral therapy for any reason, because if you had someone undetectable, you're like, oh, don't mess it around, because there really weren't great other options. Nowadays, we have other alternatives. And, you know, if someone has terrible asthma and they need to breathe, that's more life-threatening than the HIV, okay? So it's really about balancing. Maybe we need to put them on a higher dose, stronger steroid for their asthma and actually switch their antiretroviral therapy to take away the booster. And so there's no reason from an HIV virologic control mechanism, like there's no reason why someone would have to be on Genvoya. You could just take away the booster and give another INSTI regimen, like sort of like you could use bictegravir or dolutegravir with the same backbone of tenofovir and emtricitabine. I would just probably, this is a great reason to take that person off boosted elvitegravir. And so if there was an insurance challenge, like, hey, their insurance says I have to use boosted elvitegravir based regimen, you would say, hey, here's why. And you'd have to do a prior authorization and basically advocate for your patient that they need to be on a different integrase inhibitor that's not boosted. The other not boosted integrase inhibitors will not have any interaction with that steroid.
Correct. I'll continue to work with him. I think he's attached to the Genvoya because he was, you know, been on it for so many years, got him virologically suppressed. So he feels like this is the medication that's worked for me, that has saved my life. I don't want to stop it type of situation.
That is so common. I think with any switch, even if you, like, people are having ongoing like diabetes and peripheral neuropathy and like pancreatitis, and you're like, bloody heck, you know, like you need to switch your meds. And so that is a challenge. I think one of the things I always tell patients is, you know, when we're switching because of toxicity or drug interactions or something, it's not because the medicine isn't working. So if we had to switch back, we could, okay? And so often my patients feel a little bit more comfortable knowing like, hey, if this experiment that my doc wants to do, you know, doesn't work, I know I can always switch back. But most people are happy with less side effects of medications that don't have boosters in them.
Thank you.
Yeah, thank you.
I am going to make a question on behalf of one of my colleagues, Delia Rivera. I practice pediatric infectious disease at the University of Miami. She has a young adult who, of course, in due form, he got lost to follow up for some time, stopped taking his medications. And then when she reinstated treatment, she put him on a 3TC abacavir and boosted atazanavir, and from there she went into the Genvoya combination, brand name. In this combination, it has been very successful about bringing down the viral load to undetectable. However, the CD4 count remains in the basement. I know that once you hit below 50 cells, it's very difficult to come up, but his nadir was 95 CD4s, and the CD4-CD8 ratio is now, it went as low as 0.08 actually. Her concern is, are we seeing this as a paradoxical response, or is this just that it's taking a very long sweet time for that CD4 to come up?
Yeah, thank you so much for that question. It's so common. It's just taken a sweet time, as you're saying. So the lower someone has been for a longer time, the less likely they are to fully rebound, and the slower that rebound is. Including if they're older, it's slower. If they have co-infection with Hep B or Hep C, if they're using alcohol or other substances, it'll be slower as well. But this is not uncommon. And if the viral load is undetectable, then it is a quote unquote successful regimen from that standpoint. So it would not be a reason to switch just because of the CD4 rise is so slow.
Okay. Yeah.
So basically just reinforce adherence.
Absolutely.
Thank you for that question.
Yeah, teenagers are delightful.
They are. So I know you didn't ask me the question, but of the integrase inhibitors, raltegravir, which is dosed twice a day, but now there's a single dose formulation, and boosted elvitegravir, which is in that Genvoya combination, have the lowest barrier to resistance in that class of medication. And so for a teen with intermittent adherence, I would prefer to be on one of the newer, put my patient on one of the newer integrase inhibitors, dolutegravir or bictegravir, because I think it's more forgiving for missed doses than the raltegravir or the elvitegravir boosted. But I know that wasn't your question, but couldn't help myself.
But she's planning to switch him to, she put a Dovato at some point. So dolutegravir and God only knows what else is there. So
yeah, so that I would be resistant to dolutegravir lamivudine in this patient with prior experience to medication and not good adherence. So in this case, I think this would be an example of someone who I do not think should be on that 2-drug regimen. Prior treatment experience, low CD4 count, intermittent. Yeah, I think not.
I'll let her know. Thank you so very much.
We're about to start the other session. I want to make sure people have time for a break, and I'm also facilitating the next session, so I have to be there on time. I just want to quickly answer that question about if someone had a rapid screening for HIV, is that enough for a rapid start? And that really depends on the particular patient and situation. So if it was someone who, let's say, is pregnant and is more likely to have a false positive antibody, then I'd want that confirmation. If it's a very sort of slam dunk patient, you're like, oh, they've got all the signs and symptoms, I'm positive they have HIV, then you could start. If they're insured, right? If they're not insured, then how are you going to access the medications? Some of the assistance programs or Ryan White programs require a confirmation test before they qualify for antiretroviral therapy. And again, in many settings, we can get that confirmation test in one day. And so it really depends on your setting. So there is more than one right answer. Here in our setting in New Mexico, we have to get confirmation testing, particularly for uninsured. But if I had an insured patient and it was a slam dunk, I would start right away. Thanks everyone for your questions. I really appreciate it. We'll see you at the next session.